Once again, thank you for the opportunity to talk, and congratulations. It's been a very interesting program so far. I've been asked to kind of continue on with the earlier topic to talk about the endovascular repair of complex aortic dissection and really kind of focus more on the outcomes. And I think because we've had such a good introduction to thoracic stenting for acute type B dissections and kind of medium disease, so disease after 14 days of the acute event, we're starting to think of dissection patients more in the realm of intervention. And you'll see, this is Harvard data that just came out this year, basically saying that if we operate on people with dissection, they're far more likely to have a better life expectancy over time. And this melds really well with the data that we're getting also about thoracic devices alone in dissection, being that they don't change the natural history of disease. So in fact, if we don't treat the whole aorta, we're probably not going to change the patient's outcomes. So what we have to do then is figure out a way to treat the entire aorta, and endovascular options are certainly aplenty. And especially if you read the literature, sometimes custom devices aren't always possible, and it's important to be very creative when you're thinking about ways of doing things. This isn't a technique that I would personally approve of, but it certainly got the job done. And what you'll notice is that some of the same problems that we have in fenestrated or branch stenting also crop up in these other more creative ways of treating the aorta. What we have to remember is ultimately we're not just dealing with flow, we're dealing with pressure. And the goal of treating any form of dissection is changing the pressure differential between true lumen and false lumen so that the true lumen takes over and the false lumen ultimately closes. And even in true lumens that are extraordinarily small, you'll notice that over time, if you design the device properly and if you really change that pressure differential, you will see ultimately the true lumen gets bigger. I thought it would be kind of cool because it's always nice to look at pictures, to do a case. This is a Marfan's patient treated quite a few years ago with open repair of the thoracic aorta and then a residual dissection left behind in his visceral aorta. And you can see that the true lumen is extraordinarily tight. The patient had a lot of cardiac risk factors, and therefore the decision was made to go ahead with endovascular treatment. And you can see that the device designed, much like in the last case, has a constrained true lumen below the visceral segment. And in this case, we made the decision to confine the top cap so that we would have some opportunity to get into the celiac artery, and I'll show you that in a second. Once again, fusion imaging is incredibly important in marking the visceral vessels so that you have standard markers. Once the device is in place, this time we deployed the entire main body all at once. This was much earlier in my experience, so before I had the wisdom of years. And then progressively cannulate all of the vessels, much like you do for a regular fenestrated device. In this case, we had placed a stent on the left side to bridge the false lumen. It makes it so much easier to see the left renal, and you'll notice the use of a preloaded renal catheter allows us to really kind of find the fenestration easily. The goal of design is to make everything as easy as possible on the day of implantation. The big reason why I want to show you this case, however, has to do with the celiac artery, and you can see here that it's extraordinarily steep. And the goal was to use the top cap to get some downward motion for the celiac artery so that once we actually did get into it, we were able to bounce off the top cap and get the wire in place. And in a very unconventional way, we made the decision that there was no way that we'd be able to stent this and then get back in to flare it once we'd lost the top cap. And so we went ahead and actually stented the celiac artery before deploying the device. This breaks one of the prime rules of fenestrated procedures, but it just goes to show you that in dissection, you need to be creative and you really need to think outside of the box in order to sometimes get the repair that you want. The rest of the procedure went as normal, and you can see that this is the visceral segment angiogram before the distal device was placed, which is why there's still quite a bit of false lumen flow. The other unique thing about this patient was that he had a really big iliac vessel, and so this just shows you that you can place a branched iliac graft in on the same day, and let me cut forward because we're running out of time, and get into the iliac and ultimately repair all of the aorta down to normal sealing zones with an endovascular repair. And there's the iliac branch outcome, and this is what it looked like finally. So this is the patient I showed you earlier, and you can see that his repair matured quite well, despite the fact that he was a Marfan's patient, and despite the fact that he had a lot of challenges. So what is the published literature on complex repair? Well, there are a couple of series and a couple of case reports, one being a really great case from this center. And you can see that there's a variety of different types of devices that are used in order to repair. And at the end of the day, the all-cause mortality and the target vessel patency doesn't appear to be that different compared with complex endovascular repair for regular degenerative aneurysms. And when we looked at this in Cleveland, we broke it down according to extensive dissection and focal dissection, recognizing that the group of focal dissectors were people who we were able to completely exclude the false lumen in the first session. And you'll notice that that does have an impact on whether or not the aneurysms go on to shrink without further reintervention. And in fact, if you can't get the false lumen excluded, it stands to reason that you do need further reintervention in order to get the false lumen to shrink. But at the end of the day, complex endovascular repair can be used in dissection, and I believe it's probably an option that we should keep. They're tricky cases, but the global experience is growing, but it's actually getting a lot more favorable. And I think you have to be prepared to follow up these patients afterwards and look at the false lumen, because they will inevitably have endoleaks that need to be treated.